the topic, the debate is why either one, why chemotherapy, antibodies, or CAR T? Why not like how we sequence therapy, how we can do offer them in the best optimal way? Because the problem we face here in the USA is patients who failed multiple agents, they get CAR T at the end of therapy after failing everything, and the outcome is really poor. I think CAR T should be used earlier, and I don't think there are options they're competing with each other. I'd like to hear from my colleagues, what do they think?
I would agree. Short answer.
Elias, we definitely agree even from the pediatric side. The question is that how to get in practice this idea, because unfortunately, as you know, this is not possible, at least in our setting, okay? Because the registered condition for the commercially available CAR T is not along the way you described.
But if it is approved for relapsed refractory ALL, correct?
Only in children after another therapy, right?
No, but
And in young adults.
but the Zumatry, the Tecartus is approved
Yeah,
for
that's
relapsed
the
refractory ALL.
adults, yes. But I think one of the big problems is that, I mean, it's a matter of having everything ready to go with a CAR T when you have an explosive relapse. And that's the biggest issue, I think, with the autologous CAR T cells. It takes time to get that all approved and move forward. So are you suggesting to use it before before patients relapse in the setting of MRD?
What I suggesting, Wendy, is when you have somebody relapse, so what we're doing in Houston right now is we call the insurance to get approval for CAR T, correct? But that, as you said, will take months to get things in place. Then we can give them the best salvage we have, and they do CAR T thereafter as a consolidation, either
Yes.
an MRD negative or MRD positive. That's what I'm trying to say, and that should stay within the label.
No, you're right. It does. It's just I thought you were suggesting that we should be using CAR T right away at the time of relapse.
No. What I'm saying is CAR T sequential. Let's say you used inotuzumab for salvage, okay, or mini-CPD, or whatever you want. So we gave the first course of treatment. At the time of the recovery, we collect the cells to prepare them for CAR T. That will give me 2 to 4 weeks. I can give a second course, and then give the CAR T thereafter.
Yeah, I mean that's possible. Certainly
May I give
expensive.
may I give a pediatric answer to at least to recapitulate what had happened in Europe since the approval of Kymriah. After the approval of Kymriah with very advanced ALL or very refractory patients, we went to companies to say, okay, but if we hope that we will replace transplant, the very logical setting is the first relapse. So we went for months and even years to discuss with Kite, with Novartis, etc. Whatever the design we propose, randomized, monoarm, etc., selecting the very high risk relapse, which is another discussion in pediatrics, what is standard risk relapse, what is high risk relapse. Nevertheless, all the discussions have failed. So the situation at the moment for pediatrics is if you want to have access to first relapse, then you have to show that your first relapse is refractory. So then comes some kind of, let's say, play, because some people will give, for example, vincristine prednisone and show that the MRD is still so elevated after this kind of thing that the patients could be thought as refractory. The other thing is we are planning for these very high risk first relapse, less than 18 months, 119, 17, 19, hypodiploid, MLL, or high MRD after standard risk relapse induction. We are planning a so-called VHR in trial 2020, where the patients will receive exactly like Elias told, one course of inotuzumab, and then academic CAR T if we succeed to set up an academic platform, at least one in each country in Europe, to give academic CAR, probably given by Miltenyi, which resemble the Kymriah anyway, and try to not to transplant those patients. So These are the situations. So as you can see, first relapse, maybe it's doable, as Elias said, for adults in US. At the moment, it's not for children in Europe. That's my point.
And also, I think that in the US, there was a similar study in the COG that was closed because it was sort of, as you were saying, Andre, that, to try to avoid transplant in these very high risk relapse. This was actually in the MRD setting.
Now, the study you're referring to is on hold, and
Yeah,
it's not
that-
for relapse. It was very high risk first
very high risk
line
MRD.
patients.
Yeah, but the reason they ended up closing it was because people were still taking those patients even after the CAR T to transplant. And so they just closed the study, is what I understand, for that reason. So it's complicated. I think people don't yet feel comfortable using CAR T in these very, very high risk patients, especially ones that have relapsed, as a quote unquote destination therapy, and that they're still taking them to transplant, which has been my approach as well.
So if you have somebody who's MRD positive, let's say you get a patient who received salvage therapy, okay? And for whatever reason, transplant was not done and he's MRD positive. Will you consider CAR T for these patients in a salvage, I'm saying, second CR, or anituzumab or blinatumomab?
I think in most European countries, it will depend on the age of the patient. If the patient's older than 25,
Yes.
there's no choice but blinatumomab or inotuzumab or so, but CAR aren't reimbursed or approved.
Okay.
Yeah.
But Tecartus will be now because it's approved above 26 years of age, Oliver. So there is a big discussion because the paper of Tecartus is not so clear about the outcome of patient not transplanted. They are saying in the paper, but with a very short median follow-up, that some patients can survive without transplant, despite the fact that this CAR T construct does not lead to persistence, which is at least currently the dogma for cure in ALL. So question is, will you go for, to the question of Elias, will you go for MRD, will you go to Tecartus plus transplant, or will you go to Tecartus only, or will you go to Blina, transplant, or whatever?
I mean, my bias in the adult would be that in a relapse situation, if I can get that patient into remission, that's great, and then I go for transplant. I would in the salvage situation not be convinced by any MRD as low as it can be that transplant can be avoided. It might be individual patients, but I have to make a decision, and I would go for transplant as the ultimate consultation.
Conservative but logical option, I would say.
That's what
I
I
am conservative, yeah.
No, but it's logical.
Yeah, no, that's exactly the approach. And I think that that's what makes it hard. The question really is, how comfortable do people feel at this moment with just using CAR T as the quote unquote destination therapy? And I personally don't feel comfortable at this moment with that in this very high risk population, who then are able to get into a second remission. I would take them to the transplant. And that's a lot to go through, as we know. So that
part of the question which is asked on the slide is, how will you bring those patients to transplant?
Yeah, I think exactly. I think there are a couple of questions that this raises. One is, do they need the transplant? And then if the answer is yes, then do you really need the CAR T cell to get them to the transplant?
And then if we go to CAR T, do you think there's a place where CAR T will suffice as end therapy, or transplant is still an option to be considered post-CAR T?
No, that's what I was saying. I think that's what we were just, I thought that's what we were talking about.
Correct.
But yeah, I don't think I feel comfortable in the majority of cases who are able to, if patients are able to go onto a transplant, I would take them to a transplant.
No, but Wendy, I meant if you do CAR T, will you do transplant post-CAR T?
Yes.
You still, even if you're MRD negative by NGS post-CAR T?
Yes, because I think the data are are very slim on the long-term follow-up. And if you look at the survival curves, people are continuing to relapse after, more so than if after an allo in an MRD negative setting. Because so it's an open question, and maybe with the evolution of the new CAR T generations with more durable responses, or these, less T cell exhausting approaches with these lower affinity, lower avidity CAR Ts, maybe that will change. But I think right now, I think the question is open, but I think I don't personally feel comfortable not taking those patients to transplant if they're eligible.
Wendy, this is Andrea. Are you decided independent of any other variable, let's say BCA lost over, let's say, the MRD, as Elias said? In other words, you are moving towards allo independent of the loss of B-cell aplasia or the appearance of the MRD or the subtype of genetic.
Yeah. Well, but I have to say that recently I haven't been using that approach, the CAR T approach, as the bridge to transplant, because of all of the issues we just discussed. It's hard to get them to the CAR T, and then if they can get into a deep remission with INO or followed by Blina, for example, then I would just take them to the transplant after that, rather than even using a CAR T in that setting. For me, the idea of CAR T, maybe at the moment, the way I have been thinking about it, is more as for patients who have relapsed after an allo, who have already relapsed after an allo. Then I would think about it more as a destination therapy, because maybe if it's an autologous CAR T, then maybe you're still using the donor's CAR T, the donor's T cells as the engineered CAR T.
There is a question by Helen Albrook.
I just wanted to agree with both Oliver and Wendy, and also say that even if the label will be there for the CAR T, you might not be able to use, because you might have reimbursement for the real refractory patients or the patients beyond the allo transplant. So I suppose it's not ready yet in Sweden how to be able to get the CAR over 25, but I could assume that it could be that you should be refractory for all drugs, or for most modern drugs, or being refractory, relapsing after a transplant. So even if the label is there, you might not be able to get your hands on it.
In addition to these practical issues that we are facing here in Europe that Elaine just mentioned, I mean, CARs, in my view, still don't work all that well with high tumor loads. I mean, they work in a subset of patients, but it's not all that great. So I think that would be a case for starting off with something like Blina. I mean, ideally, of course, a trial with some combination. But it could be an interesting trial, actually, to take a patient and then either achieve, and if you achieve a deep remission, then either go to transplant or then have another consolidation with CAR T. Essentially, probably numerous designs that one can think of, but to introduce a randomized question around the optimal consolidation or bridging therapy to transplant. And we're not very good at doing randomized trials in that setting.
I do think that it is the theory that all people would like a randomized trial, randomizing since the relapse, one attitude versus the other one. But I do think it's unlikely to happen. And for example, we have 4 stakeholders tribune in pediatrics called Accelerate, where you have the regulatory agency, the pediatric oncologist, the patient association, and the pharma. And we had one on CAR T-cell. And you would have seen the patient association arguing against randomized trial in this issue, because wrong or right, they do think maybe they can spare their children from transplant.
Yeah, that's the point.
So because you know, Oliver, that the recent randomized trial in transplant has still demonstrated that TBI is necessary, and TBI means infertility, cancer, blah blah blah. You know the song. So
Yeah.
a lot of people would love to try to avoid transplant or to reserve transplant to patients who lose B-cell aplasia in the first 6 months, for example, or patients who have an MRD detectable at day 28, because those two factors are really predictive of a potential failure of CAR T cell. Obviously, the one that you told about, which is extremely high burden, is also a major fact to consider. Considering genetics, it has not been proven in the field of CAR T cell that genetics brings something, but with the potential exception of p53 mutated patients. So that's where we are in the field of pediatrics, which I recognize is unstable, but we will learn in the coming years. There is a question, but I don't see who. Jose Maria.
Dr. Ribeiro.
Yeah, I think that for an adult, for adults, we have to consider the relapse if there has been a previous transplantation or not.
Of course.
If there is not a previous transplantation, immunotherapy, combine it with mild chemo and transplant is the choice now. If the patient is previously transplanted, I think that we have to use the same immunotherapy and a little chemo, and then CAR T better than a second transplantation. And if the patient is unfit, the question is clear: immunotherapy followed by CAR T. I think as a general way of doing things. This is general and sometimes is not feasible, but I think that we have to approach to this area of working.
Thanks, Jose Maria.